Thanks for taking the time today. I'm Nate Denny, an ALS provider here at Capital Medical Service. I've been asked to talk to you all a little bit about opioid toxicity, or overdose, what it is, how it works, and what we're going to do about it. When we're dealing with opioids, or if we suspect we are, it's important to know what they do inside the body. Our entire nervous system has receptors specifically for opiates. When used properly, these substances can decrease pain signals going to our brain and produce an analgesic effect. It diminishes the pain we're feeling. When someone takes too much, however, it has an effect on the receptors in the brain, particularly the medulla. The medulla is the part of the brain responsible for, among other things, regulating our breathing. It does this in two ways. There's the hypercarbic drive. It triggers us to take a breath based on the levels of CO2 it detects in our blood. We also have the hypoxic drive, which triggers us to take a breath based on the level of oxygen in our blood. High levels of opioids interfere with both of these drives. Enzymes in the liver take the inactive chemical form of an opioid and activate it by changing it into the chemical form that binds to these opioid receptors in our nervous system. Because some people have multiple copies of these enzymes in their livers, they can activate them very rapidly. So even a small dose of an opioid can be toxic for some patients. Most of us know the most common illegal opioid, heroin. In some places, even opium can still be found. But prescribed opioid medications are also widely abused in the U.S. Among these are morphine, codeine, and tramadol. We also have hydrocodone, which is called Vicodin, Norco, and Lortab. There's hydromorphone, which we better know as Dilaudid. You can find oxycodone, known as OxyContin, Percocet, or Percodan. There's Demerol and oxymorphone, found as Opana or stop signs because of the shape of the pills. There's even methadone, which is commonly prescribed to help addicted people stop using opioids, and it can still be abused. Probably the most frightening form of opioid medication available on the streets right now is fentanyl, a narcotic roughly 100 times more powerful than morphine. Because it's easy to manufacture, many other street drugs like cocaine and Molly will get cut with fentanyl to make them more addictive. Some opioid overdoses happen when the victim doesn't even realize they've taken an opioid in the first place. Almost any street drug could contain toxic levels of fentanyl. Opioids are effective when swallowed, smoked, snorted, or injected. Specific forms of fentanyl can also be absorbed directly through the skin in a medication patch. Be sure to wear gloves if you remove a medication patch from a suspected opioid overdose. Our frontline medication for opioid overdose is Naloxone, or Narcan. What Narcan does is pry the opioids from the receptor sites on our nervous system and prevent any more opioids from binding to them. Because of all the ways that opioids affect the nervous system, look for an overdose by checking these three things: altered mental status, pinpoint pupils, and their respiratory rate. Our protocols here at Capital are specific. They only allow the administration of Narcan in cases where we see respiratory depression. That's a respiratory rate of less than 10 breaths a minute. Their pulse oximetry reading has nothing to do with it. Think about it this way. Only single-digit respiratory rates get Narcan. Just because a patient isn't breathing less than 10 times a minute doesn't mean they're not on their way to respiratory depression and you just caught it before they got there. Reassess these patients constantly. In cases where they are in respiratory depression, begin assisting ventilations with a BVM right away while you're setting up to give them Narcan. Do not delay ventilations just to give this medication. If you can, try and identify the substance this person took, how they took it, and whether or not they have a past history of opioid abuse. Passing this information along can help them with their long-term and their short-term care. We've determined that we have a patient with opioid toxicity and they have respiratory depression. We're going to administer Narcan intranasally in a fine mist through the nose that absorbs directly into the tissue. If you haven't done it, roll the patient supine and begin assisting ventilations. Check your medication. Make sure it's Narcan. Check the expiration date. Take the Narcan vial and the syringe out of the package and remove the caps off of everything. You want to check the contents of the vial for any visible contamination. Once you've done that, screw the vial into the plastic syringe. Take the mucosal atomization device, the MAD, and screw it in place on the prefilled syringe the same way you would a needle. You want to push all the air out of the syringe and prime the MAD with the medication. You should see a puff of fine mist spray out of the MAD if any escapes. If you push the plunger too softly, it causes a stream to come out instead. We want that mist, so when you give this, press that plunger pretty firmly. Our dosage of Narcan for an overdose with respiratory depression is 2 milligrams. Narcan comes in a concentration of 1 milligram in 1 milliliter, so we'll be administering 2 milliliters total. That's a whole vial. Studies show that no more than half a milliliter of fluid delivered intranasally can be absorbed at any one time. We want all of it to be absorbed by the tissue in the nose and sinuses and not drip down the back of the patient's throat. The way we're going to do this is we're going to split the total dosage into 4 administrations of a half milliliter each, given one at a time. Either you or your partner check the medication one more time before you give it. It's still Narcan, it still hasn't expired, and it still looks clean and free of contaminants. Place the MAD into the patient's nostril gently until the spongy tip fills up the entire opening. With your free hand, use one finger and gently hold the other nostril shut. Spray 0.5 milliliters into the patient's nose. They may cough or spit. The medication tastes terrible if it drips down the nasopharynx and onto the tongue. Then you're going to switch nostrils. Put the MAD in the other nostril, push the first one shut gently with one finger, and administer another half a milliliter. Repeat the entire process one more time, once more in each nostril, until your syringe is empty and the entire 2 mils has been administered. The prefilled syringe is glass, so dispose of it in the sharps. If you need to redose, which we can do every 5 minutes if there's still respiratory depression, we use a fresh syringe and a fresh MAD every time. Write down the medication, the dose, the route, and the time in your report. What we're hoping to see is the patient's respiratory rate come up, back into the double digits. Once you've made the clinical determination that this patient's breathing adequately, you can direct your partner to stop assisting ventilations and switch to oxygen by non-rebreather or even a cannula. Keep a close eye on the patient's O2 saturation. The longer they breathe at that depressed rate, the more hypoxic they're going to be. You want to keep those O's flowing until they're back to around 95%. Because of the way Narcan works in the nervous system, cleaning all the opioids from the receptors this quickly will save their life, but it could also push them straight into early-stage narcotic withdrawal. Patients who receive Narcan can wake up disoriented, irritable, despondent, or even violent in a few cases. If the patient got a fentanyl overdose from a street drug that's a stimulant, such as methamphetamine, remember, Narcan only works on opiates. We can wake them straight up into a methamphetamine overdose or a cocaine overdose as well. Remember, always keep yourself and your partner safe. If the patient does start to cough or spit, chances are you didn't push hard enough on the plunger to create that mist, and you sent a stream of the medication into the patient's nose to drip into the pharynx. That'll also mean that hardly any Narcan got absorbed, and you might need to give the medication again. You should see the effects of intranasal Narcan in about 5 to 10 minutes after you give it. Intranasal Narcan has a really long half-life. Around 2 to 2.5 hours go by before it starts to wear off. The problem we face usually isn't that the medication we gave wore off, it's that we didn't give enough. Some of the prescription opioids we've talked about are very strong, and some are time-released. It can take 2, 3 doses of Narcan sometimes to reverse the respiratory depression from a high dose of fentanyl, versus only 1 dose to reverse it from a heroin overdose. Since this is the case, our protocols authorize us to repeat this 2 milligram dose of Narcan every 5 minutes until the respiratory depression's gone. The best advice is to aim for the sweet spot. Administer just enough Narcan to correct the depression, but not so much that the patient wakes up in withdrawal. This is a lot easier to do when Narcan's given through the vein. If you have an ALS provider on scene, talk to them before you give them another intranasal dose. The ALS provider might prefer to start an IV and give any additional Narcan that way. Thanks again for your time. As always, if you have any questions, send them up the chain and we'll get them answered for you as quickly as we possibly can. Once again, we appreciate the care and compassion you show your patients more than words can express. Be safe out there.